Hi, everyone. Thank you so much for joining today. We're going to give it just another moment and then we're going to get started. All right. Hi, everyone. I'm Meredith Whitmire. I'm the Policy Director for Defeat Malnutrition Today. And welcome to today's webinar on collecting data on older adults, opportunities to learn about nutrition status. In case you're unfamiliar with Defeat Malnutrition Today, and I know quite a few of you were referred by the Academy of Nutrition and Dietetics, which is a fantastic founding member of DMT. We are a coalition of over 100 stakeholders, and we are working to create policy change toward a greater emphasis on screening, detecting, treating, and preventing malnutrition. So today's speakers, we have Jamie Gash from the National Institutes of Health. We have Debbie Reed-Gillette from the Centers for Medicare and Medicaid Services, and we have Kristen Robinson from the Administration for Community Living. I'm going to give a quick introduction of each of our speakers, and then I will turn it over to Jamie. So Jamie Gash joined the NIH's Office of Dietary Supplements in January 2017 as a nutritional epidemiologist in the ODS Population Studies Program. Her work focuses on assessing the use of dietary supplements in the United States and investigating the role of dietary supplements in disease prevention and health promotion, using data from health surveys and epidemiologic studies. Her work in recent years has also focused on malnutrition and frailty screening and how measures from these tools can be used in our national surveys. Prior to joining ODS, Dr. Gash worked as a nutritional epidemiologist at the CDC National Center for Health Statistics in the Division of National Health and Nutrition Examination Surveys. Dr. Gash received her BS in Nutritional Sciences from Cornell University, her MPH degree from the George Washington University, and her PhD in Nutrition from the University of Maryland, College Park. Our second speaker will be Deborah Reed-Gillette. She's director of the Survey Management and Analysis Group within the Office of Enterprise Data and Analytics of CMS. The primary function of SMAG is the Medicare Current Beneficiary Survey, the primary survey providing health and healthcare data on Medicare beneficiaries. The MCBS has collected data not available in CMS administrative data to aid in the development and education of evaluation of healthcare policy since 1991. In addition to her time at CMS, Ms. Reed-Gillette has over 35 years of experience in federal health surveys with the CDC, including the National Health Interview Survey and the National Health and Nutrition Examination Survey. Additionally, she has served as a subject matter expert for the Oregon Health Study, the first New York City Health and Nutrition Examination Study, the Canadian Health Measures Study, Survey of the Health of Wisconsin, and the National Children's Study. Prior to rejoining the federal government in 2014, she served as technical lead and project manager for the National Content Developer Contract in providing technical assistance and advice to 26 hospital engagement networks and their 3,700 acute care hospitals engaged in the Partnership for Patients, a CMMI-funded initiative focused on reducing hospital-acquired conditions and preventable readmissions. And then our third speaker is going to be Kristen Robinson. She has worked in the field of aging since 1998, beginning her career as staff director for the Federal Interagency Forum on Aging-Related Statistics. As staff director, she worked closely with senior officials and program staff from 14 federal agencies to facilitate collaboration among agencies that share a common interest in improving aging-related data. Today, Kristen is a senior research scientist for social and scientific systems and works on site at the ACL as the project director for the Aging, Independence, and Disability Program Data Portal. She also assists the Office of performance and evaluation by managing the day-to-day activities of the National Survey of Older Americans Act participants, identifying emerging areas of research, and participating in strategic planning to strengthen ACL's core research and data collection activities. Kristen received her doctorate degree in sociology and demography from Penn State University. So I would also like to let folks know that we are going to have a Q&A period. We ask you to send in your questions throughout, but all three panelists will be answering questions at the end. And with that, I would like to turn the presentation over to Jamie.
Okay, great. Thank you for that introduction. So I'm very happy to be here today and have the opportunity to share with everyone some of the efforts that I've been involved with, focused on national surveys and what's included in terms of nutrition measures and other health measures that can really help us to better understand what's going on in our older adult population regarding conditions like malnutrition and frailty. I want to mention my other colleagues that I work very close with on this, Dr. Johanna Dwyer, also at NIH, and Dr. Mary Beth Ahrensberg at Abbott Nutrition. Okay, next slide. Okay, so as many of you probably already know, older adults made up 15% of the US population in 2016, and that percentage is projected to grow to about 24% by 2060. And this has many implications, and the need to prepare for an expanding population of older adults is critical. So meeting the diet and nutrition needs of older people is a crucial part in the effort to, of course, maintain health, functional independence, and quality of life for older adults. So under nutrition, or specifically what it's really what we're talking about here is protein, energy, malnutrition, and I'll just be saying malnutrition from now on, and frailty are important interrelated issues that face our nation's growing older adult population. And so with malnutrition in older adults, it's often due to reduced intakes of protein and energy combined with many other factors. So these factors include biological changes in the digestive system, reduced physical activity, subsequent loss in physical strength, lean muscle mass loss, chronic comorbid conditions, polypharmacy, social factors. And so malnutrition can lead to many of the same poor outcomes as frailty. It can also cause frailty, further exacerbate it, often overlaps with frailty in the same individual. And so all of which have adverse impacts on the functional as well as health outcomes of older adults. And just to mention, frailty is, now one of the top 10 geriatric concerns. And while the definitions of frailty can somewhat differ and continue to evolve, the general agreement is that frailty is a state of vulnerability, non-resilience with limited reserve capacity in major organ systems. So this really makes it difficult to withstand the impact of trauma or disease, again, leading to that increased risk of independence and disability, risk of dependence and disability. Next slide, please. So we know as our population of older adults increases, the number of older adults at risk of malnutrition and frailty will also increase. So having accurate information on the percentage of risk in the US population and in subgroups of the population is really critical. And this data can be collected as part of many of our already ongoing nationally representative surveys that collect data on older adults and also health. The information, of course, provides statistics so that we understand the magnitude of the problem and to help provide vital information to inform policies to address the problem. Having data collected over time also allows us to evaluate the progress or impact that some of the policies may have. I like to really drive the message that, without appropriate data collected, it becomes very difficult to set national goals. So for both malnutrition and frailty, they continue to be left out of national goals such as Healthy People 2030, owing in some part to the lack of standardized measures to accurately screen older adults, but really the lack of consistently available data to be able to estimate the prevalence and incidence of malnutrition and frailty among older adults in the US. Additionally, having standard validated screening tools or standard measures that are used in both our community settings, hospital settings, and in our national surveys make it possible for communities to benchmark or compare to national estimates. So I'm not going to get into a lot about screening tools today because we're really focusing on surveys, but just briefly, next slide, please. About a year and a half ago, we decided to conduct a study to gain some understanding of what frailty and malnutrition measures our federal surveys already are collecting that could be used to estimate the percentage of older adults in the US that are at risk for frailty or malnutrition. So what we did first is we reviewed many of the commonly used malnutrition and frailty screeners that are being used in communities, hospitals, and then we took these screeners and we made a list of the measures that are included, and we looked at basically what measures were common in both frailty and malnutrition screening tools. So we came up with these lists, and again, just to mention some of the screeners we looked at for frailty, about 9 screeners: the Frailty Index, Fried Phenotype, Prisma 7. For malnutrition, we looked at the malnutrition screening tools, Screen 1 and 2, mini nutritional assessment short form, so common screening tools. Next slide, please. We then went on to identify federal surveys. We ended up identifying 8 that included older adult participants as well as collected data on health. And what we did was we reviewed more recent survey protocols, or what was being collected from these surveys, typically in the years of 2017, 2018, and 2019, to see if they collected any of these measures that were listed in the previous slide. So these measures that were from the frailty, malnutrition tools, the common measures. So we wanted to review all the surveys and see, what they have in terms of nutritional information and physical functioning status and things like that. Next slide, please. Okay, so these are the 8 surveys that we did identify. I'm not going to go over this slide in great detail, but briefly, the 8 surveys that we identified, collected data either specifically on older adults or included older adults as part of their sampling. These surveys also collected data on health, and many of them a wealth of data. The surveys really differ in the number of participants. We have some surveys, with 1,200 participants at a time to up to 90,000 persons per year. They differ in various aspects of study design. For example, some were cross-sectional or collecting data at one point in time from a participant, or longitudinal, collecting data at multiple points from a participant. Many of the surveys at the time that we queried were conducted in the participants' homes, some over the phone or a mix of phone and in person. And they differed on how data was collected, with a few of them collecting, well, most of them collecting only self-reported data through questionnaires, and others combining physical measures and questionnaires. Next slide, please. Okay, so just to jump right into the results. So of these 8 surveys that we looked at the protocols, only 3 surveys actually collected physical measures. And they were the National Health and Nutrition Examination Survey, or NHANES, the National Health and Aging Trends Study, or NHATS, and the Health and Retirement Study, or HRS. For NHANES, these measures included measured height and weight, anthropometric measurements like waist arm circumference. They actually also have a DEXA scan. They have a short dental exam that provides data on dental health, tooth loss, use of dentures. And I just want to mention, NHANES also collects a lot of biospecimens. So data also on albumin levels, things like that. So for the NHATS study, they collected some body measurement data, specifically weight, waist and arm circumference, so actual measured data. But they also did a great job at collecting data on physical functioning and strength. So they did measures of grip strength, gait speed test, and balance. And then finally, HRS, they also collected a variety of body measurements and measures of physical functioning. And I want to mention physical functioning is a big part of assessing frailty and is really critical to identify those at risk. So these are great measures to include. And for both NHATS and HRS, they also collect measures from participants at different points in time, which can be very important in understanding how both body measures and physical functioning can change over time for an individual. So for all the other surveys, all the surveys in general, they include questionnaires. And you can see for most of the surveys, 6 out of the 8, they do ask about height and weight, it's self-recall. And while we prefer an actual physical measure for better accuracy, for many surveys, this is not feasible. And it's still very important information to collect. Only 2 surveys, the NHANES and NHATS, collect data on unintentional weight loss. And while I didn't get into the different screeners, there are a couple screeners that have been validated in the community that include just a few measures to identify malnutrition. And these key measures are, the unintentional weight loss and appetite loss. And you can see that only 1 survey actually asked participants about appetite loss. A few of the surveys asked about appetite changes, but didn't specify whether it was an increase in appetite or a loss of appetite. So that is exactly what we're looking for. 4 of the surveys collect data on physical activity level, and you can see that all the surveys, which is great, collect lots of questions on physical functioning and mobility, and the ability to perform activities of living. This is really important data. Of course, physical measures are very important too, so that functioning, for example, can be measured in a standardized way for all participants and not self-reported, which can be impacted by many factors. But again, it's not always feasible in all surveys, so it's just great that this information is being collected in all of these health surveys. I'm sorry, next slide, please. So I just wanted to highlight 3 of the surveys, and then our other speakers will be highlighting 2 surveys that I've also included in the list, 2 of the other surveys, and they'll be getting into more detail about those. As I highlight the surveys, I also wanted to mention there's a little purple box, and these are just potential measures that could really help us, if they're added to a survey, to get a better idea of the prevalence of both malnutrition and frailty in the US among older adults. So first, the National Health and Nutrition Examination Survey, or NHANES. This is a nationally representative survey, collects data on the health and nutritional status of the US population. It's cross-sectional, and it collects information from participants using questionnaires, physical examinations, and the collection of biospecimens. When it comes to information on data important to malnutrition screening, or even nutritional status in general, this survey collects, again, a wealth of information, collects physical measures such as height and weight, so that we can calculate body mass index. The survey has DEXA scans, very detailed information on dietary intake, questions on cognition, physical functioning, and information on unintentional weight loss. And so in looking at NHANES, we determined that just the addition of questions on appetite loss, adding grip strength data, these certain things would really help to provide nationally representative estimates on malnutrition and frailty potential. Next slide, please. The Health and Retirement Study is a longitudinal study that has been collecting information on the health and economics of adults 50 years and over for more than 20 years. Physical measures and questionnaires are also used to collect information from participants, again, such as height and weight, grip strength, other physical functioning tests that are great, cognitive functioning assessments. Appetite loss, however, it needs to be refined a little bit because it's only asked about any time in a year and doesn't really have a specific time frame. So with just refining the question on appetite loss, adding in unintentional weight loss, adding a few diet questions to the study, this would also be a great resource to help us provide more important information on risk of malnutrition and frailty. Next slide, please. And then I wanted to highlight the National Health and Aging Trends Study, also a longitudinal study that collects data on older adults 65 years and older. collects an enormous amount of data, and very importantly, also has physical measures along with questionnaires collected. This study collects so much information that's needed to assess risk of malnutrition, including height, weight, unintentional weight loss, grip strength, cognitive functioning, physical functioning, with some changes again to the appetite loss question and some simple questions added on diet. This study would also be able to provide very important information on malnutrition and frailty in older adults. And this population, just to note, is specifically Medicare beneficiaries. Next slide, please. So in conclusion, I just want to mention we have so many US national surveys that collect so much information that could really help us. There's so many opportunities to add several simple measures to our US national surveys that are already ongoing that would permit the collection of more complete national data for identifying malnutrition and to begin to identify frailty risk. Many of our national surveys already, again, are collecting so much information on the health of US older adults. Additional nutrition measures, physical functioning measures in general would allow researchers an initial means to assess potential prevalence and also to help policymakers set national goals, really in the effort to support maintaining functional ability, well-being, and helping older adults to age in place in their communities. With that, I'm done with my presentation, and I will be turning it over now to Debbie Reed-Gillette.
Thank you, Jamie. As Jamie said, I'm Debbie Reed-Gillette, and I am the director of the Medicare Current Beneficiary Survey. Next slide, please. So the Medicare Current Beneficiary Survey is a nationally representative, continuous in-person longitudinal study of the Medicare population, those 65 and older, and those who are 64 and under who are on the Medicare rolls due to certain disabling conditions. MCBS is sponsored by the Office of Enterprise Data and Analytics within CMS, and it's conducted through a contract with NORC at the University of Chicago. And the MCBS has been designed to aid CMS in administering and monitoring and evaluating the Medicare program. And we are the leading source of information on Medicare's impact on beneficiaries. We provide a lot of information that is not available in the CMS administrative data, and we play a very essential role in monitoring and evaluating the health status and how the healthcare policy of the Medicare program affects the beneficiaries. Next slide, please. So we've been collecting data since 1991. And we've been in the field continuously for almost 30 years and have conducted over 1 million interviews by thousands of respondents who are Medicare beneficiaries. Next slide, please. So some of the things that can be considered distinguishing features of the MCBS is that we're able to actually link the self-reported information to administrative claims data and administrative enrollment data that's currently part of the Medicare program. We also collect a lot of information about events and costs and services to the beneficiaries that are not covered by Medicare to get a full picture of everything that affects our Medicare beneficiaries, including complete sources of payment and out-of-pocket costs. And the MCBS also uses a rotating panel design. This design allows us to conduct longitudinal analysis, and our beneficiaries are enrolled in the survey for up to 4 years, and we conduct up to 11 interviews on those beneficiaries. We collect the information 3 times a year, and we refer to this seasonally. And while we collect some information every round, we also collect some information only at one point in time each year. Next slide, please. One of the things that the MCBS does that a lot of our federal surveys don't do is that we follow our beneficiaries into and out of long-term care facilities, such as skilled nursing facilities and long-term care. We continue to collect information while they are in these facilities so that we can get a true picture of how their care transitions. We oversample Hispanic beneficiaries with disabilities, those who are under age 64 and on Medicare. and those who are 85 and older, so that we can make sure that we have a good sample for analysis purposes and estimates. Next slide, please. So we do release this data for analysis and make the data available to researchers. We have 2 files that are available called limited data sets that with a data use agreement, researchers can use. We have our survey file, which contains all of the self-reported information, as well as linked fee-for-service claims and other administrative data from the Medicare program. We then also release a cost supplement file that's used in conjunction with the survey file that can allow you to look at their utilization of services in the healthcare, in their healthcare landscape. Each of these LDS files contain multiple files called segments. They're usually topical in nature, and they're linked by one beneficiary ID. And you can also utilize this over years to track the same beneficiary. Next slide, please. So our Medicare population files are designed for our survey, are designed by the Medicare population year. We look at the benefit year, January 1st to December 31st, excuse me. And so we would refer to our files by that benefit year. Our most recently released data is for our 2019 Medicare population. That data was collected from August 1st of 2019 through November 30th of 2020 on that population. So our survey file contains demographic information, health insurance coverage information, not only for Medicare, the type of Medicare, but also any private insurances that they may have, self-reported health status and conditions, chronic conditions, responses regarding their access to care and satisfaction with their health care. And all of this data is collected directly from our respondents. And as I said, our cost supplement file allows you to look at their utilization of health services. During 2019, for our 2019 population, we were also able to collect information on how COVID-19 affected the beneficiaries in both summer of 2020 and in the fall of 2020. Next slide, please. As I said, our MCBS uses a rotating panel sample design every year. We have one panel that rotates off the survey, and we enroll a new panel into the survey. We are designed to collect about 14,500 completed cases annually. And then when we look at the ultimate release of the file, there's usually about 12,500 to 13,000 individuals on any annual file. This is a nationally representative sample of our Medicare population. You can't actually do state or local estimates, but you can do national estimates as well as some regional estimates. We use the administrative enrollment data to select this sample. Next slide, please. And I've already discussed how we actually look at our sample, and we'll go to the next slide, please. So within these 2 surveys, the survey file and the cost supplement file, we have 2 separate data collection instruments, our community and facility instruments. We also look at our individuals as either baseline interviewees or continuing interviewees. And we have both core and topical supplements that we ask them based on their location, as well as whether they're new to the survey or whether they're continuing in the survey. We do allow some proxy responses for some of the items, but some of the items must be answered by the respondent themselves. Next slide, please. So here you can see all of the information that we actually collect on the survey, including, as I said, their sociodemographics, health insurance, health status and functioning, both chronic conditions, their health status, preventive health utilization, nicotine and alcohol use, their experiences with their care, how much their costs are for their health care, what their characteristics of their housing is and who's living with them, what are their health behaviors, what types of prescription drugs are they using and those patterns of use. And we're able to supplement that with the administrative data collected within the Medicare program. We also ask them about chronic pain, their decision-making, COVID-19 experiences as well. Next slide. In our facility instrument, we actually utilize a lot of the information that's required to be reported by participating Medicare facilities called the minimum data set. A lot of these items have a parallel in our community data collection where we're asking the individual respond directly. But when an individual is in a facility, we don't ask them directly what the responses are. We instead use the facility administrators to answer the questions on the beneficiary's behalf and extract the information from their healthcare record. Next slide, please. So as you can see, a lot of the similar topics are available in the facility instrument as they were in the community data collection. Next slide. So our new content that began with our 2019 survey file is, first of all, we've been able to actually collect the impact of COVID-19 on our beneficiaries, including their vaccine uptake. In 2020, we were able to introduce cognitive screening questions, including backwards counting, date naming, object naming, and naming the president and vice president of the United States. In 2021, we began to ask them detailed questions on their internet usage. In particular, do they use the internet to access their healthcare? We've also added questions on malnutrition and dietary supplement use. And in 2022, we're hoping to introduce physical measures, including timed walk, sit to stand, measured height and measured weight, and grip strength. We had been hoping to add those items earlier, but because of COVID-19, everything had to be delayed. Next slide, please. As I said, our implementation of the physical measures has been delayed due to the COVID-19 pandemic because we had to transition to a telephone-only survey at that point in time. We're looking at a mixed mode right now and looking to introduce these measures beginning next spring as a pilot test, and then introducing these measures in full beginning next summer. So our multiple measures being implemented are using protocols from the National Social Life, Health and Aging Project, NSHAP, which is currently conducted by NORC. Measured height, measured weight, balance, gait speed or timed walk, and chair stands to measure balance. We're also going to be implementing the grip strength protocol using the NIH toolbox for assessment of neurological and behavioral function. Next slide, please. So for these data products, as I said before, we allow researchers to use a data use agreement and get our limited data set release. We also have some of our data available in a public use file. And we do produce a lot of items in a chart book that allows you to look at trends over time. All of the information, documentation, and methodology reports are available on the CMS website. We're very excited to be able to begin to implement these measures of frailty, including the cognition, the malnutrition questions, and the physical measures to help identify the impact and burden on the population as we look at our Medicare population, which continues to grow at an annual rate. Next slide, please. This is just a quick view of and our website address so that you can go out and take a look at the study and request access to the data. And next slide. And thank you. If you have any questions at the end, I'm happy to answer them. And please go out to our website. And we also will answer any questions if you direct them through the website about our study. And with that, I'm going to turn it over to Kristen Robinson. Kristen.
Great. Thank you so much. I'm so happy to be the third person today speaking because I've learned so much already. It was great being mentioned in Jamie's presentation as one of the surveys that she's looked at. And in Debbie's presentation talking about the MCBS, ACL loves the MCBS. We use those numbers for our disability estimates because they include the institutionalized. And in fact, we borrowed some of the estimates for questions for the COVID, from your COVID module that I'm not going to mention today because the ones we borrowed didn't talk specifically about nutrition, but Yeah, we love the MCBS, so this has been exciting. I just want to say, as was mentioned in the bio, I'm usually an on-site contractor, but because of COVID, I am remote, and I work in the Office of Performance and Evaluation for Susan Jenkins. She's the director, and I help with the National Survey of Older American Act participants, the day-to-day managing of the activities, and I'm happy to be here. So next slide, please. The National Survey of Older American Act participants, we call the NSOAP, and there are 6 different surveys within this one family of surveys. Today, I'm focusing on home delivered meals and congregate meals because I figured that's what the audience would be most interested in. We have added a rotating module. It was supposed to be added last year, which I'll talk about in a minute, but it's in the field now on COVID. So it's, again, something similar to MCBS and a lot of other surveys out there that have kind of realized that more data needs to be collected on this event. And luckily, we're able to get the questions out there in kind of a rapid response method as opposed to the usual amount of time it takes to get new questions into the field. Next slide, please. So the NSOAP is administered as a telephone survey to a random sample of older American Act service recipients. The primary purpose is to provide the aging network with outcome information that demonstrates the effectiveness of services and illustrates client-reported quality of service. So really, it's about the service and not necessarily about the health status of these older adults, but we do include health questions, which I will go over in a few slides. There's about 6,000 people in our sample. We're winding up this summer's survey right now, and we are just about there, so that's exciting. We weren't sure what was going to happen with COVID, but we are almost there, so that's exciting. Next slide, please. The NSOAP measures the extent to which goals of the Older Americans Act have been met. For example, targeting, access, and coordination. The results of the NSOAP support ACL's yearly budget request to Congress. The budget request is accompanied by a 200-plus page justification, and included in the section on health and independence of older adults are results that show the extent to which the services help clients remain living independently in the community, and that's where the NSOAP fits in. The results of the survey also support program design by allowing ACL to better understand program and service trends, and results have been used by ACL-funded resource centers to design and target technical assistance efforts to the aging services network. Next slide, please. This is a slide I put in just to show you who our clients are, and I'm sure many of you know this already. The question that is asked of both congregate and home delivered meals is to think of a typical day you eat a meal from the senior center or meal site. Of all you ate that day, what portion of all the food you eat in a day does this meal represent? Would you say less than 1/3, between 1/3 and 1/2, about 1/2, or more than 1/2? And as you can see in this strange pie chart, if you add the dark blue and the orange together, you get about 55% of the congregate meal clients say that the meal they get there is half or more of all the meals they have that day. So that the idea is to show our clients are frail. They rely on this service greatly. And as we'll, perhaps talk about a little bit, COVID has come in and changed their world. If we go to the next slide, we show the same chart for home delivered clients. And as you may expect, if you add the blue and the orange together, you get 61%. So that's a large number of people that say the meal that they get from the home delivered services represents half or more of the meals they eat that day. So our services are important, and we need to make sure that we are collecting as much data and useful data as we can about the people receiving these services. Next slide, please. These are some of the questions I just picked out from both the home delivered and the congregate. They're asked of both. Both surveys include them along with a bunch of other questions, but do you eat healthier foods? as a result of the meals? Does receiving home delivered or congregate improve your health? Do the meals help you to continue to live independently? That's really important, especially for our home delivered meal clients. And as a result of receiving the meals, do you feel better? And if we look at the next slide, I just put together a quick chart to show you, the people who say yes, who answer yes, we really rely on these meals for a lot of reasons. They make us feel better, live independently, improve our health, eat healthier. These data are from 2019. I must say that these are pre-COVID, but they do rely on the meals, and we see that, and we use this information in our congressional justifications. Next slide, please. So before I started helping out with the survey back in 2016, there were 6 USDA questions, which I'm sure many of you are familiar with, that were considered a set of 6 questions, and we considered them for the ENSOAP. Starting in 2019, 3 of them were included as a regular part of the core survey. So the question begins with, I'm going to read you several statements that people have made about their food situation. For the first 2 statements, please tell me whether the statement was often true, sometimes true, or never true for you in the last 12 months. Next slide, please. And then the first 2 are, the food I bought just didn't last, and I didn't have money to get more. The next question or statement, I couldn't afford to eat balanced meals. And then the third one, in the last 12 months, did you ever cut the size of your meals or skip meals because there wasn't enough money for food? And that's a yes or no answer. So these are what we call our USDA questions, and they are in the core, so they'll be asked every year. Next slide, please. COVID. Due to COVID-19, ACL decided to postpone the 2020 NSOAP so as not to increase the burden on the area agencies on aging, the state units on aging, and most importantly, the Older American Act service recipients, our clients. While ACL originally planned to do a module on emergency preparedness in 2020, a decision was made in consultation with ACL's leadership and regional administrators that a module on the effect of COVID-19 on access to services made more sense. ACL convened a new advisory work group consisting of members from different state units on aging, area agencies on aging, academia, and advocacy organizations. I think some of you are on this call, I believe. The advisory work group members were divided into 3 subgroups, focusing on nutrition, family caregiving, and overall well-being, which included transportation, case management, and homemaker services. Those are 3 services that don't get the support they deserve in research. Work group members discussed, evaluated, and ranked proposed COVID-related questions. They also provided input and feedback on relevance of existing survey questions. The nutrition work group was led by Carrie Lipperini and Judy Simon from ACL. And I'll just add that not only were these groups tasked with coming up with new questions for COVID, but also removing or at least suppressing some questions from the 2021 survey because we didn't want to overburden our respondents. They were going through a lot. We didn't want them to have to answer as many questions as we usually ask them. So it was an important job for them to not only tell us what new questions should be asked, but what we could skip this year and think about for the next year, as including it for the core part of the survey starting in 2022. Next slide, please. The advisory group discussed questions such as what changes in service due to COVID-19 affected clients the most. I think we just discussed that. They reviewed, they edited, ranked, and voted on questions for the COVID module, including which items need to be prioritized and which would not be relevant. Next slide, please. And this is just the purpose of the module, to measure the effect the pandemic has had on older adults' use of OAA programs and services, to measure the impact of stay-at-home orders and quarantine on Older American Act clients' ability to receive services, their satisfaction of services, and their well-being, and to measure the impact of social distancing on feelings of loneliness. Next slide, please. So all of the people in all 6 surveys were asked COVID questions. The first, I just pulled out the ones that had to do with nutrition for this presentation. So the first set of questions, I'm going to read to you two statements that people have made about their food situation at home. Thinking about you and your household, please tell me if the statement is often true, sometimes true, or never true. Next slide, please. So everyone received these questions. Since COVID, I worry whether food would run out before more can be bought or more can be delivered or picked up from a meals program. Since COVID, the food that I have just received, I think there's a typo there, sorry, didn't last. I didn't have money to get more. Next slide, please. Another question that everyone received, which I know what my answer is for it, but in the past 12 months, have you lost or gained weight without trying to lose or gain this weight? This was an important question among the nutrition advisory group, and I'm sure many people out there have opinions and I think would agree because there was such strong sentiment that we had to include this question. And by the way, the results for the survey the early results will probably be out in November. Next slide, please. In the past 12 months since COVID, have you tried to get meals, food, or groceries from your area agency on aging, but were unable to? And then why, if you said yes, why were you unable to? Next slide, please. And this is where just the meal clients, home delivered meal and congregate meal participants received these questions. In the past 12 months compared to before COVID, would you say how much you rely on meals or food from your area agency on aging has increased, stayed the same, or decreased? Next slide, please. This one was an interesting one, and I'm very curious to see what the results come back as, because not only were they asked in the past 12 months since COVID, how have you been receiving your meals or food from your area agency on aging? If they said they were receiving any of these, they were then asked, would you like to continue receiving your meals this way? So this is an effort to help ACL plan ahead and see what worked and what didn't. Next slide, please. Pretty straightforward. What type of food or meal do you most often receive? And coming up with some of these topics, food box and shelf stable, there was some discussion on what was the most appropriate way to describe the meals people were receiving. This is just the one question that congregate meal participants received. Did you receive your meal in an in-person group setting? If no, what did you miss? And then the very end, it said, okay, if yes, you were receiving these meals, please tell us, how did that work? How did they figure out a safe way to get people together to eat in a congregate meal setting? Next slide, please. And then finally, I just wanted to highlight that there were a three-part series of evaluation of Older American Act Title III Nutrition Service Program, the process evaluation, cost study, and client outcome. Not only at this website, this URL that you could see, are the reports from these evaluations. There are several fact sheets, easier to understand, shorter reports that really take the information. There was so much information in these three large evaluations, and they just make it manageable to understand and maybe pull out some data, some additional data on access to food, malnutrition. I just recommend you take a look at that URL and see if there's anything there that would be useful to your work. And then the final slide, I just want to say thank you. The NSOAP is available at that website, aged.acl.gov, the data, the questionnaires, the code book, the SAS output, and there's my email. I'm happy to answer any questions if you think of them after the presentation. And I think we go to Meredith now for questions.
Yes, absolutely. Thank you so much to our three presenters. This was fantastic information, and we do have some questions. I'm going to start with a couple of quick ones for Kristen. Are the recipients who are called actually picking up the telephone these days?
For the most part, yes. We are still finding that people like to talk, and that the caregiver support, family caregiver support recipients are a little harder to get, and that survey is a little longer. But as far as the other programs, not surprisingly, it's been harder to get people to talk about congregate meals because they just haven't been happening. But yeah, we are getting people to answer the phones. It's great.
And I would second that, Kristen, for the MCBS, even though we transition from in-person to phone, our response rates for our incoming panel that we invite, as well as our continuing beneficiaries who will continue on the survey, we're having great response rates. They like to talk about their Medicare program and they like to talk to us.
That's great. Kristen, also quickly, is the NSOAP available state by state? And when will the COVID-19 portion be available?
It is not available at the state level. It's a national survey. I think we do have regions. Not that many people use regional data, but it's there. And we expect the first set of results to be available in November. I'm not sure. I don't think we'll be publishing it on our AGID website, but if someone were interested in receiving the files, they could certainly contact me or ACL in general, and we could see if any files were ready to be analyzed.
All right. We have a bunch more questions. I'm glad people are very engaged. Susie was wondering, are there studies to investigate malnutrition identified as contributing factors to death on the death certificates of the elderly, specifically with evidence of diagnosis of malnutrition in the individual's medical record? So, is malnutrition being listed on, death certificates, and is it being listed on medical records? Do those two match up?
This is Jamie. I can sort of start this. So I'm not aware of studies that specifically investigate malnutrition as contributing factors to death on the death certificates or in medical record. However, I can speak to the national surveys and the fact that many of them are actually linked to Medicare claims data as well as the National Death Index. So you can look into things like this. And for example, there was a study published a few years ago, was using NHANES data, and it was using the survey data, and the authors put together a 36-item sort of frailty index. They constructed this on their own based on the data collected from NHANES. Then they used, the data is then also linked to the National Death Index. So they looked at the association with frailty and different disease and death, and all-cause death, and then death-specific, certain condition-specific death. And they did find that while the nutrition-related factors by themselves were not associated with mortality, but combined in this frailty index, they did predict mortality risk. And so for this, it's very interesting, and it's really a great source and opportunity, again, with our surveys, because they are linked to Medicare data, because they're linked to National Death Index. If we had some measures where we were able to look at risk for an individual for malnutrition or frailty, and then be able to then compare and see if those conditions, malnutrition, for example, is listed in their Medicare claims data or in their National Death Index, this would give us more of an idea of, do we see this being indicated? Because I assume malnutrition as an underlying cause should be there on the death certificate, but I don't know that this is consistently done in a standardized way.
Thanks, Jamie. So another question, and this is for Deb, and I actually also have this question. Does the MCBS cover Medicare Advantage enrollees? And if not, is there something similar for those enrollees?
Yes, we cover all Medicare beneficiaries, those enrolled in traditional fee-for-service, as well as those who are in Medicare Advantage. Yep. And we also include the administrative data for Part D enrollees with all of their prescription detailed events. So you can look at polypharmacy and prescribing patterns.
For the telephone interviews, and I think this is directed at Kristen, but Debbie, I'd be interested to know the answer for this for the MCBS as well. Do the telephone interviews take place in multiple languages?
For us, it's just Spanish or English.
We are officially translated in English and Spanish, but if the beneficiary speaks a language other than English or Spanish, we allow them to bring a translator. And so we conduct the interview in whatever the language is that the beneficiary needs.
Great. This question is also for Debbie. Since clinical nutrition from acute care and primary care is known to be underreported, clinical malnutrition, how do these other reporting systems account for that? Would this data also underreport? And the questioner also says she's very pleased that you're adding specific malnutrition measures, grip strength, and gait speed.
That's a great question, but I don't know the answer, but I will actually go back and find the answer for you and report back to you if I can have your contact information.
Great. I can if this questioner would type that into the question box, I will pass that to you. And finally, our final question, and if anyone else has any further questions, I will pass those along. Does the information that the MCBS collect support the provision of medically tailored meals as a paid benefit? So is that information pointing toward that as being a good solution or benefit to offer?
I know that currently that Medicare Part B does cover some medically necessary foods, especially for those who have diabetes or kidney disease. I don't know that they are actually doing currently research for that benefit. They may be doing that under one of the CMMI models. But at this point, that's not a benefit that I am familiar with, except for those medical nutrition tailored foods for diabetics and kidney disease.
All right. Debbie, you also mentioned that MCBS data are linked to claims in order to collect some of this utilization data. Is it possible for CMS to link this data such that respondents can be referred to federal nutrition programs if applicable?
That's very interesting. We actually provide our beneficiaries when we're interviewing them with a list of resources. And we do ask them oftentimes about, when we're asking them about their knowledge about particular programs and benefits, if they had ever heard of it prior to the interview, and then provide them information, for instance, about a program for Meals on Wheels or other nutrition programs, or information about their Part D drug plans, et cetera. But we don't actually link the data directly back to the respondent from their claims. That's usually done by their medical providers. But we actually don't, do that based on their fee-for-service claims or their reporting.
All right. I believe that is our final question. I'd like to thank our panelists so much again. This was fantastic. And just wanted to point out that there's some resources on the screen for you. And we are recording this webinar, and the slides and the recording will be up on our Defeat Malnutrition Today website in the next day or two. So thank you once again. And I am going to end the webinar.